right, well, let's all get started. I'm Sally Bovey. I'm a fellow in the child psychiatry program, and I wanted to introduce Dr. Matt Lally today. We're very excited to have him here as he came through our program, and now he's one of our supervisors. And as I was looking over his CV, I was really interested in his college experience. It's pretty impressive. He went to Holy Cross and got a BA of English Literature and spent some time at Oxford as well as an undergraduate. Then he did his pre-medical work at Tufts and also some work at Harvard for pre-medical stuff, and then went to UMass for medical school and came here for internship, residency, and the child fellowship. And from here, he went on to work at Cottonwood to Tucson. And he is now the director of adolescent medicine there and an adult attending as well. So please welcome Matt Lally.
Hi, thank you so much. Thank you, Sally. It's good to be here. Can you hear me okay? All right. Well, and will the lights be on the whole time? Okay, thank you. Well, thank you for having me here. I really appreciate the opportunity to speak at your Grand Rounds. And I think you have some great speakers, so it's an honor to be here today, and I appreciate your attendance. I want to speak about lithium today. You know, as I was looking at the slides, the physiology of lithium, it's not exactly the most glamorous lecture you could ever give. It sounds like a good lecture if you have insomnia to listen to. But I'm hoping it will be more glamorous or more exciting than that. The goal of my lecture today is for myself, and hopefully for you too, perhaps, is the clinical understanding of lithium. That's really the bottom line of this lecture. And the outline that I want to use is first to talk about the history of lithium, and then to talk about the risk versus benefit balance of lithium. And in that part of the lecture, I'm going to talk about the physiology of lithium, somewhat, evidence about its risk and benefit, and also just some general useful clinical facts that can be used when prescribing lithium. Basically, as I approach this lecture, where I'm coming from when I see patients, if there's a concern regarding bipolar disorder, are two questions that I ask myself, very fundamental questions. One is, does this patient have bipolar disorder? And two, what medication should I recommend? That's really what I think of when first meeting a patient. And this lecture today is not going to answer these two questions. I don't think any one lecture could answer these two questions. But maybe, in my mind, maybe understanding lithium will be a piece of that puzzle. It'll be one component of these two questions. With the first question, does the patient have bipolar? Some things that I face, some challenges that I face is the diagnosis isn't always clear. If the patient's hypomanic or manic, is this medication induced? If it's bipolar type 2, am I meeting somebody with a personality disorder? If there's a history of substance use, do they have bipolar disorder and that has maybe predisposed them to substance use? Or does the erratic behavior, is it just a consequence of substance use? And lastly, in seeing adolescents, there's two other additional factors. One is an adolescent can have perhaps an emerging bipolar disorder that isn't quite clear yet, and also issues related to ADHD and comorbidity. Some questions regarding what medication to choose, or factors, is to look at individual side effect considerations, a family history of response to a certain medication. Sometimes I ask myself the question, how sure am I of the diagnosis? And that may lead me towards one medication or another. How risky has the patient's behavior been, or what risk do they pose? And lastly, not a small question, what will they agree to? And I don't know about you, but sometimes that's an issue as well. So that's kind of where I'm coming from in this lecture. Some disclosures. First of all, as maybe you can guess with a lithium lecture, there's no financial disclosures. Secondly, I want to let you know I'm not a lithium researcher or a bipolar researcher, so I guess I just better say that so you know where I'm coming from. And lastly, there may be a pro-lithium bias here. I've been working on this lecture, and anytime I think you give a lecture, there may be, at least for myself, there may be a bias towards what I'm talking about. So I should probably put that out there as a disclosure. And I'll be curious on your thoughts if you have your own experiences or reflections on lithium. The other thing I should say is looking out, I think there are people here with more clinical experience than I have with lithium, so I'm open to your feedback and your observations, and at the end we have a discussion. I'm okay with that also. I should also say at this time, my wife, who's not here, she helped me with this lecture, so I should probably acknowledge her also. We might need her. She's an internist, so she could help us with some of the physiology. Well, should we talk about the history of lithium? Some of this you may know already, and I think I want to discuss it for two reasons. One is that I find it interesting, and secondly, I think it does kind of inform a clinical understanding of lithium, maybe not directly, but perhaps indirectly. A lot of this information that I'm going to present now is from a textbook called The History of Lithium by F. Neil Johnson. So I just want to acknowledge that's where a lot of this information has come. I tried to email him before this lecture at the University of Lancaster, but I think they said he's no longer on the staff there. But this is where a lot of this information comes from. And this book is from the 80s, so that's when it was written. Well, in terms of the history of lithium, the place to start is the Big Bang. That's when, for what I'm told anyway, a lot of lithium was made. The next event that's of significance is 1949. Does anybody know who that is? That's right, that's John Cade. This is the story of John Cade, kind of abbreviated. He's from Australia. He was from Australia. He obtained his medical degree in 1938. He was captured in World War II by the Japanese Army, and he spent 3.5 years as a POW. And one source that I found claimed that he came home weighing 80 pounds. I'm not sure if that's true or not, but I did see that written someplace. And this is a quote from that textbook I mentioned from John Cade. I could see that this regards his when he was captured in the POW camp. I could see that so many of the psychiatric patients suffering from the so-called functional psychoses appeared to be sick people in the medical sense. This fired my ambition to discover their etiology. I returned from 3.5 years as a POW of the Japanese, mourning the wasted years and determined to pursue the ideas that had germinated in that interminable time. So he came back apparently and tried to look for a metabolic cause for mania and depression. And he tried a number of different experiments, nothing that really led anywhere. And then apparently he injected guinea pigs with lithium urate. And after 2 hours, the guinea pig would lie calmly on its back. Now I wonder if there's any observations about that, giving lithium to a guinea pig and have the guinea pig lie calmly on its back. Any reflections on that? Apparently guinea pigs are quite skittish, especially if they're upside down. Well, John Cade was not looking at the therapeutic benefits of lithium. He was looking at the toxic effects for two reasons. One, as far as I know, lithium doesn't work in 2 hours. It takes longer than that to work. And secondly, if a person's euthymic, lithium shouldn't do anything. So he was actually seeing the toxic effects, and not the therapeutic effects. And he was mistaken about that. In any case, he proceeded, fortunately. And then he gave it to himself, which I think is kind of admirable, before giving it to other people. He did his first clinical trial on 10 patients and was published in the Medical Journal of Australia. His first patient responded robustly. I think I read the patient had been like manic for 5 years, but then eventually died from lithium toxicity. And his last surviving patient died in 1980. The same year as John Cade, after 30 years of lithium. So one question was, John Cade's discovery, was it serendipity or dumb luck? Whatever you think on that question, I think it's safe to say that if there was no John Cade, then there probably would be no lithium for bipolar. He set out to help those suffering from a mental health condition, and that's exactly what he did. A little bit more on the history of lithium. It was first mined in 1800. Discovered in 1817, and the lithium urate solution was first produced in 1841. Since John Cade, we could call this the modern era of lithium. And I put a dotted line up there because I'm not sure we're still in the era of lithium. Maybe we're no longer in that era. Maybe that era is over. Maybe now we're in the era of the atypical antipsychotics. And I'm not saying that's good or bad, but it's a consideration anyway. I think there is evidence that lithium prescriptions have gone down. One question that you may ask is that what happened during that 100 or so years between when John Cade gave lithium urate to the guinea pigs when it was first produced? You could ask yourself, why did Cade think lithium would be a medicine in the first place? And why would he have availability of it? Why would he have access to it? The answer is called the uric acid diathesis. And it kind of keeps up the idea that it took many wrong ideas to discover lithium. By the way, any questions so far? No? Okay. Well, the uric acid diathesis was an idea that was around in medicine for quite some time. And the idea was that gout was caused by the accumulation of uric acid. That's actually true. The other principle of this was that many ailments were caused by uric acid, and that's false. And lastly, the idea was that lithium urate would dissolve uric acid in the body, and that's also false. So basically, if you add it up, you had an era of quack medicine. As I mentioned, many conditions were thought to be caused by this, and this led to the popularity of lithium resorts, resort springs, lithium water, most of which didn't contain any lithium, lithium tablets, and the idea that lithium was a medicine. I guess this theory of medicine was so broad that it also included mental health. And one person who wrote about this thought that mood disorders were gout retroceding to the head. That shows how broad this theory was. During this period of time, two brothers actually prescribed lithium for the treatment, one for the acute treatment of depression and one for the prophylactic treatment of depression. And you could really say that they discovered lithium for mood disorders, and Cade really rediscovered it. So this was an era of quack medicine that led to that lithium was a medicine and that was available. And it did influence John Cade. And I think the evidence is that he never would have used it if it hadn't been for this uric acid diathesis theory. This theory had a long and expansive life. It persisted into the 20th century. It was so expansive, just as a couple of examples that I found kind of amusing. Coca-Cola had a brand called Lithia Coca-Cola, which was soda with Coca-Cola with lithium in it. And 7-Up only removed lithium from 7-Up in 1950. But in 1949, the same year of John Cade's experiment, something else very important happened that almost negated his discovery. And that was in 1948, the year before, 4 U.S. companies marketed lithium chloride as a salt substitute for those on a low sodium diet to give food more taste. And this was recommended by doctors for cardiac patients, and I think you can start to see this might be a problem. Time magazine published an article in 1949 on suspected deaths from lithium chloride and said the FDA has warned, stop using this dangerous poison at once. So the same year that John Cade has his experiment is the same year that this came out. And it's kind of interesting to me that it didn't negate John Cade's experiment. And it probably didn't because someone named Mogens, I don't know how to pronounce it, to tell you the truth. I think it's... How do you say it? Scow? Oh, thank you. And he really researched lithium, and he took John Cade's discovery, and he kind of carried it forth. There's a picture of him, and there's a book, Lithium Treatment of Mood Disorders. I got a copy of this book from Barnes & Nobles, and it's really a good book, and it's pretty short. And I think in the future, if I have patients on lithium, I may give them this book. And it's really, if you say like you're a resident or a medical student, you have anxiety about lithium, I would suggest reading this book because it's quite helpful. Now, of course, it's a kind of a pro-lithium book, but nevertheless, I think it's a pretty good book. So the modern era of lithium, 10 years after Cade, someone compiled that 718 patients were treated with lithium and 64% had responded well. It was found to be helpful against recurrent depression, and it was found to be helpful for the prophylactic efficacy against bipolar disorder by the same researcher. It's also been discovered that lithium causes problems with the thyroid, which we're going to talk about today. And it's also when the research was on safe levels of lithium. In 1970, it was approved. So that's the history of lithium, and I just wanted to cover that. Are there any questions on the history of lithium? Any questions so far? By the way, there is a handout today, but I've modified the slides, so it may not be that helpful. I mean, it doesn't go along exactly with the talk.
Wasn't there a time it was used as an antipsychotic?
Well,
Did you come across that?
you know the only thing I came across is that people, I think Cade had some of those 10 patients did have psychosis, and it didn't help all 10 patients. So I think he used it on manic patients and psychotic patients also. And there is some evidence that what I read is that it has been tried for schizophrenia, but really with not that convincing results. Yeah, another question.
What do you mean by lithium springs? When they had the lithium springs?
Oh, lithium springs is like, I guess you go to like a resort where there's water coming out of the ground, and people would go there for like a vacation and like get into the lithium water and like relax or something like along those lines. Okay, let's talk about the risk versus benefit balance. And as I mentioned, these are the three areas, the three ways I want to talk about that balance. And if you have any questions, just let me know. So now we're talking about the risk versus benefit balance of lithium. And this is the list that I compiled to try to express that. On the risk side, you have toxicity. We'll talk about that. Concerns with kidney, concerns with thyroid, and what I'll call miscellaneous risks. And on the benefit side, the idea that lithium can help with prophylaxis, with the prevention of affective episodes in the future. And also the idea that lithium helps with suicide prevention. Also, not a major aspect of my talk today, but really in any way, in much at all, but there is the concept that lithium can also help unipolar depression, recurrent unipolar depression. And my sense is that in Europe it is more used for unipolar depression. Like some of the studies I'll talk about were done in Europe where they're looking at unipolar depression. I don't see it used very much for unipolar depression, at least I haven't in my experience, and I don't know if people have experience using it in that regard. Is there anybody that uses it for recurrent unipolar depression? No. Okay.
After ECT, if you put them on lithium and amitriptyline, it lets them go longer before needing maintenance ECT.
Is that right? Yeah, I think there is. I appreciate that. I think there is some evidence for that. I didn't know about the ECT exactly, though, so thank you. When I was getting ready for this talk, when I was kind of interested in lithium, these are the two things that jumped to my mind. One is, and still is actually, one is the concern about chronic kidney disease, and the other idea is the possibility, I haven't written that on there, but the potential that lithium may be better or equal to other medications for preventing episodes in the future. And I think when I think about treating patients, I think about how can I help them right now, because a manic episode, as you know, can be a crisis, but also the idea of like helping them going forward, I think, is a powerful idea. So we're going to talk about the physiology of lithium. In terms of the physiology of lithium, down here are the kidneys and the adrenals. This is the thyroid, and up here is the brain. One thing I should say as another disclaimer is that I don't think we know how lithium actually works, and so the physiology of how it helps with bipolar disorder, in my mind, is not well understood. And there are different things you can read about, for instance, cyclic AMP or stabilizing membranes or other second messenger systems, but ultimately it's my impression that it's not understood. If people have other ideas or knowledge about that, I'm absolutely open to that. So shall we talk about the kidney? There's two types of concerns with lithium in the kidney, as you may be aware. One is nephrogenic diabetes insipidus, and the other is chronic kidney disease. To start with nephrogenic diabetes insipidus. The lithium interacts with the kidney, and that leads to polyuria and polydipsia. And as far as I can tell, the polydipsia is secondary to the polyuria. It's really the polyuria that's primary. And today, instead of just talking about the kidney, it's probably more appropriate to talk about the nephron. Lithium is going to interact with ADH, and it also interacts with aldosterone. These next few slides are just in general how ADH works. When the sodium concentration is elevated, there are osmoreceptors in the hypothalamus that activate the supraoptic nuclei, and the supraoptic nuclei releases ADH in the posterior pituitary. ADH binds to the collecting duct of the nephron, upregulates proteins called aquaporins, and water is reabsorbed, and you end up with a concentrated urine. Where the sodium concentration was elevated, it's now corrected through ADH. Lithium antagonizes ADH. In this slide, I'm showing that it kind of blocks directly ADH, and that's not the case. It antagonizes it indirectly, which I'll cover in a few moments. But just for now, this shows that it antagonizes ADH. So there's no aquaporins, the water is not reabsorbed, and you have polyuria, which is the same thing as nephrogenic diabetes insipidus. The clinical correlation of this is it puts the patient at an increased risk of toxicity. So if they don't replace that fluid, their lithium levels can go up. And I had a patient who had this. Her lithium level went quite high, and then when I went to see her, she said, well, my stomach wasn't feeling well, so I stopped drinking water. And so then I made sure the staff gave her a water bottle and that she continued to drink. That's how it affects ADH. It also affects aldosterone. When extracellular fluid is low, the adrenal gland secretes aldosterone. Aldosterone lands on the collecting tubule, the collecting duct, and sodium is reabsorbed, and water automatically follows sodium. Again, you have reduced urine output. And the extracellular fluid volume that was decreased is now corrected. Again, lithium is going to antagonize aldosterone, and it's going to lead to a polyuria. And you can see that it also leads to natriuresis as well as diuresis. This is an article from 2009 that actually a colleague of mine, when he heard I was giving this lecture, he shared it with me, and I'm sure glad he did, because it talks about why that works on a more cellular level. And as you can see, it's a pretty recent article. Basically, the article points out that the specific cell that's involved is the principal cell of the cortical collecting duct. And there's an enzyme in the principal cell called glucose synthase kinase 3 beta. And I don't know too much about this enzyme. I only know about it from this article. But apparently it has two features. One, it can do many different things, it has many different functions. And second of all, it's vulnerable to lithium. So maybe you can see where this is going. As we mentioned, ADH comes into the principal cell. These little channels are meant to be aquaporin. This is aquaporin 2, and that one's aquaporin 3 and 4. And that's how water goes from this side is the tubule, and the far side is the interstitium, and that's how water crosses because of ADHD. We showed that before in the nephron and the other slides. Aldosterone. Aldosterone works with GSK. This channel is called the epithelial sodium channel. This is on the tubule side, and over there is the sodium-potassium pump. And that's how sodium chloride crosses the cell. Now, when the patient's on lithium, lithium is filtered in the glomerulus, so it goes into the tubular fluid, and it enters the collecting duct. And it competes with sodium at this epithelial sodium channel. In fact, the channel has more affinity for lithium than for sodium. So lithium enters the cell quite easily. The problem is that the sodium-potassium pump, apparently that pump doesn't have very much affinity for lithium. So the problem is that lithium gets concentrated in the principal cell. Everybody with me so far? So what you have is you have lithium in the cell, it becomes toxic, and ADH and aldosterone don't work, and that's when you have the natriuresis and diuresis that we've been talking about for the past few slides. And that's how you get nephrogenic diabetes on the cellular level. Is there treatment for nephrogenic diabetes insipidus? Does anybody know what it is? I didn't know what it was either, but apparently amiloride is an older diuretic. It's a potassium-sparing diuretic, and it blocks the epithelial sodium channel that we just talked about. So this article says, and I guess it's been, I didn't know this, but if a patient has a lot of polyuria, you can treat it with amiloride. And it works by blocking that epithelial sodium channel, and therefore water can still cross the cell. I mean, it would seem to me, they don't comment in the article, it would seem to me that sodium can't cross because amiloride is blocking it, can't cross the principal cell. But on the other hand, I think most of the sodium is not reabsorbed in this part of the nephron anyway. It's mostly reabsorbed in the proximal tubule. One question that this article raises, and I think it's an important question, is could amiloride prevent chronic kidney disease? I mean, it can help with this acute condition, but that's quite different, as we'll see, from chronic kidney disease. And the article just raises the question. I don't think it's known, or I haven't read anything about that. So in summary, that's nephrogenic diabetes insipidus with lithium. Any questions on that? Okay. Let's talk about chronic kidney disease. In many ways, I think this is more of a concern. This is the real concern with lithium. It's generally a chronic tubulo-interstitial nephritis, although there can be other kidney problems with lithium. That's the main problem. And the idea here is that it reduces kidney function or filtration gradually over time. And it's called the creeping creatinine, because what that means is as your GFR, your filtration declines over time, your creatinine, your serum creatinine builds up over time. The idea is that it takes years to decades to develop, and at a certain point, stopping the lithium may not stop the progression of chronic kidney disease, so that's a concern. Now, the actual rate, which we'll talk about in a moment, of lithium-induced chronic kidney failure is debated. People have different viewpoints on what the real risk is. And I said at the beginning of the lecture, I come to this lecture, this idea of, probably as you do, someone who sees patients, and when I think about prescribing lithium for a patient, this idea does cross my mind, especially working with adolescents who may be potentially could be on lithium for longer. So there's two questions with chronic kidney disease and lithium. What is the risk and how to manage it? Really, the answer to both questions is, and and we'll get to this, but the bottom line is just to monitor renal function over time. That's just where all this is, the next few slides are going to be leading to. So what is the risk? It's difficult to study because it takes decades to develop, and there are other factors. Patients could have other medical illnesses. The end point is also not clear. I guess where people decide that it's kidney disease at different levels, different serum creatinine levels, people have different viewpoints of when you've crossed the threshold into chronic kidney disease. And lastly, the truth is that study results and opinions are heterogeneous, so it's hard to get a clear answer. And one other factor is that psychiatric conditions in general, even without lithium, could lead to renal dysfunction. Today for this lecture, I've selected two studies that I want to talk about. I won't go into much depth, but hopefully I'll illustrate a few points. And I was talking about at the beginning of the lecture that there could be a pro-lithium bias to this lecture, and I think if anywhere that bias comes out, it could be by certain studies that I selected, but overall I think these studies seem to be reasonable to me. The first study came out in 2009, the meta-analysis of the effects of lithium usage on serum creatinine levels. That's what we've been talking about, or we're talking about now, chronic kidney disease. They found 23 studies, and they broke them down into three groups. The first group they found, or they studied, were case controls, those on lithium versus controls not on lithium, and they looked at 9 studies. Group B was studies that looked at patients before lithium and patients after lithium, 6 studies. And Group C were prospective studies of how people did on lithium over time, 8 studies. Well, just to say a little bit about the results, I guess. A normal creatinine level is 70 to 124 micromoles per liter. Group A, in that set of studies, they found an increase of 5.7 micromoles per liter over 6.5 years. The result was found to be statistically significant, but it didn't meet the NICE guidelines for chronic kidney disease. Well, what are the NICE guidelines? These are guidelines. This study was from the United Kingdom. These are guidelines from the United Kingdom about what do you call chronic kidney disease. So this decline of GFR does not meet the NICE guidelines for chronic kidney disease. Group B, I think this was the before and after. Yeah, the before and after lithium use. They found an increase of 2.9 micromoles per liter over 7.1 years, found to be not statistically significant. And Group C was the prospective studies, and they found an increase of 7.0 micromoles per liter over 5.3 years. It was statistically significant. It also didn't meet the guidelines. It wasn't enough decrease to meet the guidelines for chronic kidney disease. And they found an average of an increase of 1.6 micromoles per year. So let me summarize this, or see if I can. So basically, it looks like these studies show a 1 to 2% increase in creatinine per year on lithium. And this was just barely below the rate of decline for chronic kidney disease by these British standards. I think I have, the limitations, it seems to me, of the studies. That the period of time in those three groups of studies I was showing you, it's 5 to 7 years. And I said earlier, with chronic kidney disease, we're talking about decades. And there's some evidence that, that between maybe 16 and 25 years is where there really are problems developing. So this may be too short. And even the authors of the study note that there was heterogeneity in the results of the individual studies that they combined. Should I keep going? Any questions so far? Okay. The second study on chronic kidney disease, what is the risk? This is from 2004, the renal insufficiency in the long-term lithium treatment. That's exactly what we're talking about. This study, they compared lithium users versus controls, 94 subjects who weren't on lithium. One limitation is that these matched controls did not have an affective or psychotic condition, so it's not an exact control, but anyway. They broke down the lithium users into 2 groups, and it kind of speaks to the bottom line of this study. They really found, or they tried to say in the study, that some individuals do have problems with renal insufficiency or chronic kidney disease, as I was just calling it, and some don't. The idea is going to be that a certain subpopulation has a problem, but other people don't have any problem at all. And that may be important to understand or when meeting with a patient. They defined the renal insufficiency group as a creatinine level greater than 132, and no renal insufficiency is below 132. And here's what they found. Those that developed renal insufficiency was 21% of the subjects. And they did have a creeping creatinine. Their creatinine went up over the years. The no renal insufficiency group, that was 79%. and they did not have any creeping creatinine. So it didn't go up over time. In fact, one thing that's kind of striking to me is that there was no difference in this group versus the control group.
This is at the beginning of the study. They had renal insufficiency before lithium, and then they were given lithium.
Let me think. I think that I don't think this was a prospective study, so I don't think they followed them over time. They just took a cohort of people and they tested their. Well, no. Let me take that back. This will help explain it. I think it's a retrospective study, but it is over time. So it's not prospective, but it's retrospective, and it's going to be over. It's over many years. This next slide is going to maybe answer that question. This is a slide from that study, and basically the dark bar represents the creatinine level at the onset of treatment, and the light bar represents after 12 years of treatment or observation. So it's retrospective, but it's over time. And what strikes me about this graph is that, was what I circled there, is that the non-renal insufficiency group had no change in their creatinine over time, over 12 years, which is a pretty good amount of time. So some patients have an increase and some don't. That's what they're trying to say. Some other interesting findings, I think, from this particular study is that, and this is not a good point, it's a little bit discouraging, but it's worth noting, and I mentioned this earlier, 12 of the 24 renal insufficiency patients, their creatinine levels did not improve after stopping lithium. So there seems to be a point of no return, and this may, the kidney obviously is not my area of expertise, but I understand this can be a feature of kidney function, and after a certain point, things don't get better even when you stop lithium. Renal insufficiency was associated with episodes of lithium toxicity and other renal illnesses or medicines. This is one that they include, and I'm a little reluctant to read it, but I'm going to read it because they put it in their findings. It's not associated with the onset of treatment. It is not associated with the duration of lithium treatment. It's not associated with the cumulative lithium dose, and it's not associated with serum lithium levels. So, like I say, I'm reading that, but I'm very nervous about reading that because I don't know if I fully understand it or endorse it. I mean, this slide kind of shows that, but still makes me a little bit nervous, and maybe at the end I'd be curious on your thoughts on that. I have read that other places too, though. So the limitations of this study is that it's retrospective, which we talked about, and also there's the question of if it had gone for more time, like the graph I showed was 12 years, if it had gone for more time, would more of these non-renal insufficiency group, would they have converted over to renal insufficiency? And I think that's still a question that I have. Well, this is about how to manage it. And this is from the British Medical Journal 2009, Lithium and Chronic Kidney Disease. This may be an article that you may have seen. Basically, the idea of this article, which I found helpful, is how to manage it. They suggest 4 steps to pre-screen, which we'll talk about, to monitor levels. It's going to be actually creatinine or estimated glomerular function, to no drug interactions, and the idea of when to stop. Everybody with me so far, or any questions so far? No? Okay. Pre-screening, what they suggest before starting lithium is get a history of any kidney disease or family history of kidney disease, get an EKG, get a BMI, blood glucose, lipids, calcium, estimated GFR, TSH, and urinary albumin to creatinine ratio. Some of these things I've never gotten. I've never gotten a urinary albumin to creatinine ratio. Estimated GFR, as you may know, is a measure of kidney function. It incorporates, it's a formula, which I haven't included the whole thing here, but basically it takes serum creatinine and it combines some factors related to age, race, and gender, and possibly it's more helpful than just a serum creatinine. This article recommended checking lithium level every 3 months. I've also seen every 6 months, and checking it 1 week after a dose, and yearly checks for blood pressure, estimated GFR, and urinalysis for blood and protein. No drug interactions. We'll talk about this a little bit on toxicity, but avoid thiazide diuretics. They increase lithium level. Caution with loop diuretics. Monitor lithium levels with ACE inhibitors, and avoid long-term NSAIDs. Aspirin's okay. This article recommends not just one measurement of creatinine or estimated glomerular function, but to watch the trend over time. Apparently, if you just get sick and you go to the doctor's office and get it checked, that can affect your kidney function. So one value by itself doesn't matter. It's a trend that matters. And there's a couple parameters that are listed in terms of when you should get a nephrology consult, when you should start to be concerned. And it basically has to do with when the GFR starts to drop. And of course, the idea is also to weigh this against the psychiatric benefit. And that, I would imagine, can be a difficult question if someone's having renal function problems. So the bottom line with chronic kidney function, it seems to me, is just to monitor kidney function over time. And there's some evidence that there was a study from France that showed that this, that this sometimes is underused. That concludes the kidney. Any questions on the kidney? Okay. All right. Well, how about we talk about the thyroid? Does that sound okay? Okay. Here's a slide representing thyroid homeostasis. It has to do with the pituitary releases TSH that goes to the thyroid and helps modulate T3 and T4, which feedbacks on the pituitary. How does lithium affect this? Well, if we go to the hypothalamus again, the hypothalamus releases thyrotropin-releasing hormone. I think this is to the anterior pituitary, and that causes release of TSH. TSH goes over to the thyroid, and if we zoomed in on a thyroid cell, TSH binds to the basal membrane of the thyroid cell, stimulates a lot of things actually in the thyroid cell, but primarily what we're interested in is that it causes the release of thyroglobulin, which releases T3 and T4. Lithium is going to act by reducing, lithium does a lot of things in thyroid homeostasis, but it seems to me the clinical aspect is that it has a relative reduction in the release of T3 and T4, and I never read an explanation of how that exactly happens, but it does seem to be a common finding. So much so that apparently in the past, hyperthyroidism, people try to treat that with lithium, and it does have some effect, but so that's evidence that it does reduce secretion of T3 and T4. So this relative reduction in T3 and T4 with lithium could lead to a potential increase in TSH. In fact, I would expect it, not an endocrinologist, but I would expect it would lead to increase, but it doesn't always lead to increase. I think the bottom line is lithium is it affects a number of different steps. Sometimes patients can have an elevated TSH, sometimes they don't, sometimes it's transient. I think the bottom line is that lithium affects multiple steps in the hypothalamic pituitary thyroid axis, and most importantly, lithium likely causes a relative decrease in T3 and T4. One finding that is common is that goiter is quite common in patients on lithium. Maybe 30 to 50% of patients have goiter. In studies, there's often an increase in TSH, but not always. Not always an increase in TSH and not always an increase in hypothyroid symptoms. And there's the question that I don't have the answer for, but it can be an important question. When do you treat subclinical hypothyroidism? And lastly, one study did not find evidence of increased autoimmune hypothyroidism with lithium. Another study said that if there's a family history, you should be aware of that because it could happen, but overall in the general population, it doesn't seem to increase the risk. So the bottom line with thyroid is kind of the same with lithium, to monitor TSH over time every 6 to 12 months. And one other idea here is that if the patient on lithium starts getting depressed, you may want to check TSH. And maybe that it's not that lithium isn't working, it's just that they're developing hypothyroidism and they're getting depressed because of that. All right, toxicity. I'm pretty sure this is the last of the risks, then we'll talk about the benefits. The basic principle is straightforward. Lithium concentration is too high. That's what leads to toxicity. It could be too much intake, such as an intentional overdose, or it could be hypovolemia, dehydration, or after a woman gives birth, apparently for that period of time, it upsets there's disturbance in electrolytes and blood volume, so that can be a risk of lithium toxicity. The other risks are decreased excretion, decreased renal clearance, or drug interactions that decrease renal clearance will also lead to elevated lithium. And also, apparently, if a person has a low sodium state, the kidney works to reabsorb sodium more actively, and in doing so, it also reabsorbs lithium. So a low sodium state could also cause lithium toxicity. Prevention, you want to pre-screen for these risks. You want to avoid dehydration. This is from Kaplan and Sadok. This is the schedule that I tend to use, but again, I'm open to other people's clinical experience. Kaplan and Sadok recommends, at least the edition I have, 300 milligrams TID, check after 5 to 6 days. And also I found somewhere kind of an interesting, I think, tidbit that an additional 300 milligrams will raise the level in general, 0.2. The lowest successful lithium dose is between, try to maintain the lowest successful dose between 0.6 and 1.0, although some studies show that between 0.8 or 0.1 may have less relapse. I think actually Dr. Gellenberg wrote a paper, or published a paper on that, the idea that higher doses can reduce relapse. Check lithium every 3 to 6 months and check 1 week after dose. This is a graph. I don't think I'll go through all of it, but it just, you can find it in textbooks and other places. It just shows what the different levels, mild, moderate, and severe toxicity are, and what some of those symptoms are. One book I saw said, don't just look at the level, look at the presentation also, because some patients, their levels may be normal, but they may have symptoms. Most overdoses are from decreased monitoring, low sodium diet, dehydration, or decreased GFR. And with an acute overdose, one positive aspect is that it takes some time to cross the blood-brain barrier, so there's a time to intervene. Chronic users have a longer lithium half-life, so they're at more risk. They're at more risk for toxicity. The treatment, stop lithium, treat dehydration. Unabsorbed lithium can be removed with Kexlate or Go Lightly. Indications for dialysis are there: coma, seizure, respiratory failure, worsening mental status. A definite reason for dialysis is acute renal failure. And you need to have more than one treatment of dialysis because there's a rebound as it comes out of, there's a rebound redistribution. One place I read said a level of 4 in a chronic lithium user is an indication for dialysis. A level of 8 for an acute for a patient who's just been started is a reason for dialysis. Well, we've talked about the history, we've talked about the risks, and let's spend a little bit of time, although I guess I don't have too much time left, to talk about the benefits. Does that sound good? Any questions so far?
You said 40 to 50%. There was a figure 40 to 50% next to goiter. Yeah. What did you mean?
Well, this one study, and it may have been up there, they checked for enlarged thyroid both on palpation and also with ultrasound. And when they checked it with ultrasound, it was more sensitive. They picked up more enlarged thyroids with ultrasound. And they found between 40 to 50% of patients who've been on lithium had an enlarged thyroid. And so it's just a finding. And other places that I read saw that happens also. Yeah?
You talked in the chronic renal failure, in the renal problems about the ADH and having diabetes insipidus.
Yeah.
And they went through the mechanisms. But what was the mechanism of chronic renal failure? Like, why does that creatinine creep happen, or what is lithium doing to the kidney?
You know, I think nobody knows for sure. I mean, remember I talked about the principal cell, how that gets toxic with lithium? There's an idea that it could be the principal cell, because that would be the right location for the problem to be. But I think that in my understanding, it's not exactly known what is happening that's causing GFR to go down. And there are histological findings, like they find cysts, they find fibrosis, but I think acutely what is happening to cause this creatinine creep is not known. Well, with the few minutes that I have left, maybe I'll talk about the benefits of lithium. I guess this isn't too much of a pro-lithium talk because I'm spending all the time on the risks and not much time on the benefits, so hopefully it's somewhat neutral. The big question that I have is lithium still the best, or is it just the first? And if it's just the first and there are other things that are better, I'm very open to that. In fact, I prescribe lithium less than I do for other medications for bipolar. For acute mania, there are other treatments that are just as effective. Lithium takes 1 to 3 weeks, and often it's recommended to use a mood stabilizer plus an atypical or benzodiazepine. Well, let's see here. Kaplan and Sadok says lithium is as effective in long-term prophylaxis as both of both manic and depressive episodes in 70 to 8% of persons with bipolar type 1. That's a rate that I think is higher than other places that I read, but that's what it says. Also they say in direct comparison, Depakote is at least as effective as lithium and is better tolerated. So that's a little word on Depakote. And one study I found said olanzapine is just as good for long-term treatment, another said it's not as good. Well, let me see. I've got two studies on prophylaxis. Maybe I'll just talk about the first one, I guess. This was from 2000. Does lithium treatment still work? Basically, what I understand about this article is that people were starting to wonder, maybe lithium doesn't work as well as it used to. So this article tried to answer that question. And they did two things. They looked at published studies from 1970 to 1996, 11 control studies and 13 open studies, and they were all long-term lithium trials. So that's part A of the study. And part B was apparently one of the authors is from Sardinia and had been following a number of patients with bipolar disorder and had been keeping apparently research quality records on these patients. So they looked at this sample over time. Not all the patients started in 1970, but that's when some of the patients started. That's when some of the information gathered. And the article calls it essentially monotherapy. I don't know what that means, if it's completely monotherapy or not, but that's what they describe it as. Here were the results of the study. When they looked at the 24 published studies of long-term treatment, this is what they concluded. These results do not indicate the loss of effectiveness of long-term lithium maintenance treatment. That was the bottom line. It looks like it's just as effective now as it was in 1970. And when they looked at this cohort of 360 Sardinian patients, they have a couple interesting findings. One is that only 32.5% of the Sardinian patients with bipolar disorder had no new episodes of treatment. And this kind of strikes me in a way. It depends if I want to see the glass as half full or half empty. From a half-full standpoint of view, that's pretty good. 1 out of 3 patients did well with lithium and had no further episodes, and that really sounds like it would improve the quality of their life. If I'm looking at the glass half empty, then 2 out of 3 continued to have problems. And the other finding was that 65% of the patients had a greater than 50% reduction in the percentage of time ill. This indicates that there's still residual illness even on lithium maintenance. So it's a mixed picture, I would say. Well, let me see now. You know what? Let's skip that slide. Suicide prevention. I'll say a few words about this. I think it's really worthwhile. This study, I don't have when this study, this study's from 2005. And what they did is they looked at 32 randomized control studies. They looked at lithium versus placebo or active treatment. And over on the side, I won't read it, but you can see the medications that weren't placebo, the other active agents that they compared lithium to. A lot of patients. The outcomes were suicide, suicide plus harm, because suicide is rare, and overall death. The lithium patients in this study were less likely to complete suicide, less likely to suicide plus self-harm, and also less likely to die during the studies, 9 deaths versus 22 for the comparators. I was talking earlier about in Europe, it looks like lithium is used for unipolar depression as well, and interestingly, one thing they commented on, they didn't see a difference in these results in unipolar versus bipolar. So there we have it. We've talked about the history and the risk-benefit balance of lithium. One final thought. I wanted to end this lecture on a quote from that textbook I was mentioning, The History of Lithium. And this is definitely a pro-lithium conclusion. And I hope it ties up all the things we've been talking about. We talked about the history, this timeline of lithium earlier. And there's one question that may come to your mind. And I bet Richard Van Rhodes is thinking about it right now, if I know Richard Van Rhodes. Here's the question. Lithium was prescribed for bipolar since John Cade. Lithium was prescribed overall, as I mentioned, because of this quack medicine theory, uric acid diathesis, for 170 years or so. So what about the 1% of patients that had bipolar disorder during that period of time when nobody knew exactly that lithium could help bipolar? Well, the author of this book that I really like, The History of Lithium, he included a section called The Unwitting Treatment of Depression. Apparently, from what I can gather, he was collecting letters on people and their experience with lithium, and this is a letter that he got. And I'll read this, and then if there's any questions, we'll take the questions or your comments, too. Here's what it said. Here's the letter to the author. I was born in 1917, and soon afterwards my mother suffered a depressive illness for which she was admitted to the hospital. Next, when I was quite a young child, she suffered from the gravel, that I think is kidney stones, for which she was prescribed lithium citrate, and she took this for almost the rest of her life. So she's taking lithium now for kidney stones, not for the depressive illness she had earlier. At age 73, she began to be incontinent. In an operation, the urologist removed a pear-sized stone from her bladder. Post-operatively, she discontinued the lithium citrate as there seemed to be no need for it. That was in 1955. Again, the idea is she's taking lithium to prevent kidney stones. And remember I said that uric acid diathesis was around for a long time. It was still alive, according to this, in 1955. Maybe you can predict what happened. 6 months later, she broke down with an agitated depression from which she suffered for 7.5 years until her death. Still at that time, nobody knew that lithium could help for bipolar. The son wrote this letter to F. Neil Johnson, I think in 1980 or 81. So that's the end of the lecture on lithium. I hope it was helpful. Any questions or comments? Yes?
You want to say it's just a word in terms of benefits about alcohol, Alzheimer's disease? Did you come across anything?
I think it's been tried. I have. I did come across things. I think it's been tried for alcohol dependence. I think the current thinking now is that it's not helpful and it's not used. I think there was a period of time when it was thought to be helpful, but the general consensus is that it's not helpful. But it was tried. And what was the other one for? Alzheimer's. That I didn't come across, but I did read for ALS. I think it's for ALS that some people are considering trying that for ALS, but so it's being tried for that. That idea that it could be used for ALS came from the 2009 article that showed that the principal cell is where the toxicity of lithium happens. Any other questions? Well, thank you so much, and I appreciate your attention today.